the clinician's role is still going to be very important because you can't take this as a completely population wide shotgun approach and just apply this to every EKG that gets done across millions of people. Because what you're going to find is that you have a whole ton of false positives. You spend an enormous amount of time and energy kind of sifting through that list, creating incidental findings that then in and of themselves have to be followed over time. And in doing so, you're really capturing the net new patients that you're identifying and capturing can be quite small. So I think that with great power comes great responsibility, right? The old Spider-Man saying. But I think it's only so true when it comes to, when is the right test for the right patient and in what circumstances should those be applied. I think that's going to become such a vital skill that we're going to need to really train on and wield as clinicians, so that we can appropriately and effectively care for patients.
Wow. Well, welcome to the podcast of the American College of Artificial Intelligence and Medicine. And we are really delighted today to have our guest, A.J. Blood, who is a cardiologist at Mass General Brigham. And I will give a brief background and then we'll get started. But his credentials are spectacular. He did his undergraduate training at Johns Hopkins, then did bench research at the NIH, followed by medical school residency at Duke, and then cardiology fellowship at the Mass General Brigham system, where he has stayed on and very much leads innovation for the Mass General Brigham, as well as been very involved with the American Heart Association at their national meetings with innovation. And we think he is just a spectacular person to have on this podcast. I'll turn it over to Ann.
All right. Welcome, AJ. Thank you so much for being here with us. We're so excited to speak with you. So maybe can we start with maybe fellowship and your journey from fellowship to your role in AI and cardiology?
Yeah, and thanks so much for the opportunity to be here with you. It's really a pleasure. So I am a practicing cardiologist and clinical trialist. I finished my fellowship first in cardiology, subsequently in critical care at Brigham and Women's here in Boston. I was also really fortunate to have a research career starting in my time at Duke and the Duke Clinical Research Institute, really blossoming at Brigham and Women's under some of the leadership of the TIMI study group members. And we really do a lot of cardiometabolic implementation science, a lot of fancy words in there. Cardiometabolic, everything from overweight and obesity to heart failure and kind of everything in between, hypertension, type 2 diabetes, hyperlipidemia. And implementation science. How do we take the guidelines, the evidence that's out there, and really be able to take that into practice, right? We know there's really great quality evidence that new therapeutics, new devices, new interventions or innovations are helpful to patients, but we also know that implementation gap can be wide. Even though the paper's been published, the study's been done, the medicine's been approved and is on the market, a lot of folks struggle to get their blood pressure to target, to get their cholesterol to target, to get their disease state under optimal management. And so from a research standpoint, we've really been focused on how do we do that better, really for the past decade or so.
Okay. When I hear you speak, I love the energy, and don't take this the wrong way, but you sound like a great internist that you want to cover everything. And I love that. We need all of that. All of it is kind of going to relate back to all of the cardiovascular risks with all of these other diseases.
You make a great point.
Managed. And I love this, that you're all inclusive here. For our readers.
You're very kind to say so.
Oh, sorry.
Pardon me.
For just maybe for our readers, can you explain a little bit about the difference of digital transformation and artificial intelligence?
Yeah, that's a really great question. So, a lot of what we've done as a research group for the past decade or so is how do we take that evidence, that data, and those guidelines and translate it into clinical practice? And for a long time, the rate limiter really has been how do we get patients access to the medical system? There's not enough doctors, there's not enough providers, there's not enough care delivery mechanisms to really achieve that and close those gaps. And so our group, for really its first few years of inception, focused on a kind of scaled provider model. And the way that we did that was we upskilled our clinical pharmacists under collaborative drug therapy management programs and under algorithm designed by physicians. They could actually prescribe. So if you think of the traditional Coumadin clinic model, we essentially took algorithms much more complex than INR shifts based on Coumadin dose, and we're able to treat conditions from hypertension, hyperlipidemia, overweight and obesity, heart failure, diabetes, really in an algorithmic approach with our pharmacists writing the prescription so that a doctor didn't need to be involved in each and every up titration or modification of a dose. But when there was an appropriate indication, our pharmacists could do that in partnership with the team that was overseeing their care. And what that allowed us to do was really at a population level. In some of our trials, including more than 10,000 patients, care for many more people in a much more scalable fashion. No in-person visit required, no minimal labs, and really doing this as from the comfort of their home as much as we were able to. But being able to check in on them with side effects, with navigators and care teams, made it possible so that we really could increase access to a lot of the care that was coming out of the Brigham, as opposed to make people drive in, pay for parking, wait for 30 minutes in the waiting room for 5 to 10 minutes with the doctor, and have to do that once every 6 months or so. It's really a model that is challenges to scale.
Yeah, all of that's so exciting, and so much is missed between those visits. And one thing that people don't realize in the office is you have your plan, you have your prescriptions, everything is in place from the doctor's standpoint. You don't know what they're dealing with at home. They can't get around. They rely on someone maybe for a ride. They don't maybe have the transportation or the money. Maybe they don't drive themselves. The vision might be off from there's so many things that happen when they leave the office. So having this within the home situation is just it's incredible. It's incredible. I love the idea, and it's like we're so proud of you that you're doing something like this. So I wanted to ask you about the DRIVE trial. So you're using the goal-directed medical therapy for diabetes and as it pertains to cardiovascular risk. Can you tell us a little bit about the DRIVE trial?
Yeah, absolutely. Thanks so much. And so that was an example of this team-based approach, right? So it was a prospective randomized trial. And we've done this in a couple different disease states now, where the model is we essentially offer this team-based approach, outreach, engagement, and pharmacist-led medication titration, and we compare that to the standard of care. And the way that we do that in a randomized trial is we actually give a time-delayed intervention. So patients consent, enroll in the trial, and in the standard of care arm, they would go about their usual business. We'd provide education, coaching, guidance on what would be the right thing for them. And some of them would reach out to their provider, try to get a visit, or happen to be seeing their provider anyway. And with that kind of activation about and education about the medications and why they're important, would get on therapy. I would say that happens in the vast minority of cases, unfortunately. In the intervention arm, we provided the same education, but also provided the opportunity for our team-based approach where a pharmacist and a navigator would take this education and say, based on these new medications, their indications, and your markers of disease, these novel therapies would actually help to reduce your cardiovascular kidney risk. And this is why. This is why we think this might be a good next step for you. In conjunction and partnership with your care team, we're now recommending you start this new therapy. And what we saw was a marked increase in the uptake, and not only the acceptance of prescription, but the taking of therapy and the ongoing completion of refills, so that we could really, in partnership with the patients, help them understand why we're making these recommendations, why these medicines are important for them, get them on the right therapy, and keep them on the right therapy. Once we were able to successfully get the guideline-directed medications as part of their medical therapy regimen, we would hand their care back off to the regular care team just to keep the ball rolling and keep them monitored and appropriately risk mitigated as new things came up. But taking that model where we are able to do a lot of the work and really medication management, side effect management, prior authorization, tier exemption. As a practicing doc, I think well, these are time-consuming, effort-inducing activities. By doing that with our pharmacist and navigator team, the care provider was able to really focus on the patient and their acute needs when they were in the visit. As you mentioned just a few moments ago, we all have a great plan walking into the ring. And as Mike Tyson said, everybody's got a great plan, and then you get punched in the face. They had a car accident and their back is killing them. Their wife just got diagnosed with cancer. their grandchild, is sick and they need, to provide more support for their kids. And starting a new medication really doesn't fit into the cards of all these other things going on in their life right now. I think there really is an important role to really, and it gets overused, but meeting patients where they are, really trying to take a partnership with them and understand that this, while this medicine might be great investment in their long-term, metabolic health, it might not be at the forefront of their mind or the most important thing they have to do that week or that month. So really trying to make this as easy as we can for them, I think is really important.
It sounds like a personal trainer. Maybe you think about working out, but if you had somebody knocking at your door saying, it's time, we're going to work out, you're going to do it. But you get busy caring for somebody else. That's what people do. You care for your loved ones, forget about yourself. But when you have somebody calling and checking in on you, that's really going to be great. It's a win-win.
I totally agree. That shared accountability is so important and really does help.
Well, we're going to shift our conversation a little bit to the topic of congestive heart failure, which AJ has done a lot of meaningful work in. Initially, when I was launching our projects on artificial intelligence and cardiology, we met with Clyde Yancey. And in that meeting, for our listeners, Clyde Yancey is the past president of the American Heart Association and chairman of cardiology at Northwestern here in Chicago. The discussion was what would be a good problem to solve in cardiology. And Clyde thought that the biggest problem to solve is the care gap between the guidelines, which he was responsible for launching for AHA, and what was actually happening in practice. And the data that we found in some of our preliminary work was that only 20% of patients were getting GDMT and that 80% had potential for improvement in their therapy. And why I'm bringing this up is the key in AI is finding an important problem to solve. And you are the one who has really tackled this better than anyone I've seen. So I really want to talk to you about this. So we noticed that you did Copilot HF. And what we really want to know about that study is AI involved in solving this guideline gap?
Yeah, and thanks so much for that great question. And Dr. Yancey is just such a leader in the field. I'm so glad that you had him on, really just a luminary. So I think he did hit the nail on the head in identifying that guideline-directed medical therapy gap as a huge challenge to us practicing cardiologists, as well as primary care providers and really anybody part of the care team. We know that these medications work. Right. And we know that they improve the quality and quantity of life of our patients who live with heart failure. And it is a major challenge getting the four pillars of medical therapy now. Really, it takes time, it takes monitoring, it takes coaching and education. And the Copilot trial, it did use AI. And the way that it used AI is really to tackle a challenge that as a clinical trialist, I unfortunately deal with quite a bit. And that's really in how do we appropriately identify those patients? And so oftentimes we use that in the lens of identifying patients for clinical trial protocols. For Copilot HF, which was a clinical trial, that's the way that we used it and essentially said, look, I want to find those right patients for whom these gaps do exist for their guideline-directed medical therapy for heart failure. However, when we see this used in routine practice, if you think of best practice alerts or other ways that providers get notified or nudged, whether it's lists of patients or CMS care gap measures or STARS rankings, where this person didn't hit that metric for their blood pressure goal or for their cholesterol goal. It's a tool, but it can be a crude tool. And the challenge is, as a provider, as soon as I get one of those alerts that I can identify as inaccurate, I very quickly say, darn those alerts, that's really not the best way to do things. I, as a provider, really know what's right and when it's right for these patients. And if I get 2, 3, 4 false alarms, like many in the ICU and other places where this type of false alarm data is studied, it turns you off to the alarm almost completely. You'll hear that beeping in the ICU almost constantly because you get alarm fatigue you get habituated to it, and it doesn't change your practice or management. So what we've been able to do is use AI to much more accurately tune this identification activity. And so what we can do is really use the unstructured data in the electronic health record, which forever has kind of been Pandora's box, right? So we know administrative data, billing data, coding data, it's much more ubiquitously available, but the quality is much lower. And the challenge with that is, if you really want to know in the weeds who's the right candidate, who's right for what, and who's, what medicines are best for what patients, you need to get in the mind of their providers, of their doctors or clinicians, and say, what's in their note? What are they saying and thinking about? And did they just not think about that medicine or class of medicine or that new surgery or procedure or that new digital therapeutic that might be perfect for this patient? Or did they think about it and they have a good reason why they didn't do it? Life happens, right? Did their daughter just pass away? Is their husband in the hospital? Are they traveling to Europe for the next 6 months? Are they moving out of state? There's all sorts of reasons why actions aren't taken by clinicians. And so being in a situation where you're being told to do something, I go open the chart and say, well, wait a second. I not only did I think about that, I documented exactly that I did think about that. I made the decision not to do it, and here's why. And now I'm upset at you for poking me to do something that I shouldn't have done for clinical, appropriateness, but I documented and told you why I shouldn't have done it. Why didn't you just read my note and understand why I didn't take that action or that next step? So the advantage of AI here is it actually can go through all of this unstructured data, not just clinical notes, but CAT scans, echo reports, pathology slides, and say, I really can deeply understand and quickly, accurately, and cost effectively ask and answer questions about that unstructured data in a way that is just so much powerful than data that comes out of structured data sets, administrative claims, and other data sources.
Great. And then just to shift gears a little into diabetes, I know you tackled the similar problem in diabetes, and Ann and I have been teaching the guidelines for decades to hundreds of residents who are now been in practice. So our whole mission in medical education is to get practicing physicians to follow the guidelines. And not only have you tackled it in heart failure, you did so in diabetes. And it was a study that you published relating to both SGLT2 and GLP-1 drugs, actually several studies. But can you comment on how you used artificial intelligence to solve this guideline problem?
Yeah, absolutely. And thank you again. That body of work I'm very proud of. I can't take sole responsibility. My research team is really a fantastic group of residents, fellows, clinical study staff, and the technology team that really has helped to build and scale many of these tools. So thank you for the kind words, but it certainly is not a one-person show. So in diabetes is similarly, looking at the SGLT2 and the GLP-1 RA landscape, there's a lot of good medicines that can effectively reduce cardiovascular and kidney risk in patients who live with diabetes. And for many reasons, cost, side effects, and lack of provider awareness, it's not always easy to get the right patients on the right therapy. And so similarly in this trial, we provided education, but we also provided this hand-holding team and using AI to really help identify the right patients for the right therapeutic, not only based on the guidelines, but based on patient preferences. Have they talked about before that they really don't like needles, that they really wouldn't ever accept an injection therapy? That's going to, at the time of the writing of these guidelines, push you in one direction or another in an SGLT2 instead of a GLP-1 array. Has this person had multiple episodes of urinary tract infections or genital urinary mycotic infections? They might not be a great candidate for an SGLT2 inhibitor, and a GLP-1 array might really be the better agent in this course. So there really are aspects that you only know either by opening a chart one at a time and having somebody who knows clinical medicine, the indications, contraindications, and reason to either choose or avoid individual therapies. It's hard to scale that, though. It's really kind of a one patient at a time activity and exercise. The major advantage that artificial intelligence and large language models can bring to these types of clinical situations is being able to rapidly, accurately, and cost effectively go through that medical documentation and say, based on the evidence that their providers have put into their medical chart, here are the things one should consider and think about. And so the technology that we developed which we actually published as part of the co-pilot trial, showed that in doing that, we published our first episode in the New England Journal of Medicine, AI, we can do it cost effectively, more accurately than our study staff, and in a way that does not impact diversity and equity. So that was a really great kind of proof of concept that retrospectively in the co-pilot trial in our heart failure instance, we could do this faster, cheaper, and more accurately than our study staff. In a prospective blinded trial that we published in JAMA, we actually showed that this can help bring more cohorts of patients to the quality of care that we're aiming for them faster. In that paradigm, we were enrolling patients in a clinical trial more quickly, and of course doing that across guideline criteria for many conditions: overweight and obesity, hypertension, hyperlipidemia, type 2 diabetes, heart failure. These are conditions that affect a lot of patients, and I think being able to do that at scale is really a big part of my vision.
Oh, this is great. So these topics are very near and dear to our hearts as internists. Of course, diabetes, heart failure, but another one is hypertension. So you had two articles in JAMA Cardiology and then also the journal titled Hypertension. Can you, and this is with home monitoring for hypertension, could you compare and contrast both of them? In looking at those, it seems as though the one that was in the journal called Hypertension seemed to be more successful. The way I look at it, they both were in various ways. Can you talk about those?
Yeah, I'd be happy to, and thanks for the kind words and the recognition. So, so these trials really looked at kind of population size data. So this is not just a few hundred; these are thousands of patients that we did in these trials, and they really were unique in a few different ways. They were similar in a couple ways too. So I'll start with their similarities. So this was entirely remote. So this was done at patients' homes, not requiring people to come into clinic for these studies. They used home-based blood pressure cuffs. They did have education and training to make sure that they were being used appropriately. And we really tried to take pretty rigorous algorithms to get a good baseline blood pressure, and then blood pressures that we would be titrating and initiating new therapy based off of. So, that would be 2 measurements in the morning and at night for at least a week to establish a baseline. That's very evidence-based. That's very high quality. It is a bit onerous on the patients. That's a lot of blood pressure readings, especially in a 1-week time frame. But by doing that, we really were able to show that this type of remote clinic, asynchronous, being able to do this with a team as opposed to sitting in front of a doctor or a nurse in a clinic, both identified white coat hypertension accurately, and really identify people who didn't need to be aggressively managed right then and there, and could be monitored more longitudinally. In addition to that, in people who were hypertensive, in our JAMA Cardiology study, we showed that we can get those people to goal very effectively. So really significant reductions, almost 15 millimeters of mercury systolic blood pressure reductions by participating in the program. Almost no matter where you fell out of the program. Not everybody, picked up every phone call, made every medication change recommendation, but just by participating, we saw significant reductions both in systolic and diastolic blood pressures. And importantly for us, we saw that using an equity lens across demographics that are traditionally underserved in medicine. So whether you were Caucasian, African American, whether you spoke English or Spanish, your area deprivation index, so your education, your income based on your zip code, we really didn't see significant differences in their ability to participate in these programs and really get the benefits of them in terms of blood pressure lowering. And as you know well as internists, right, this is an investment. Getting your blood pressure lowered over time reduces that likelihood that you, God forbid, have that heart attack or stroke. And so really at a population level, it's one of the major things we can do as care providers to protect people from having bad outcomes related to their heart and vascular health. In our study that we published in hypertension, we were able to show that while that rigorous protocol that we put people through to get that baseline blood pressure is very helpful, it's hard. And we actually did relax some of those requirements to make sure that we were able to treat as many people as we could. And we didn't really see major significant differences. So we based the initial protocol on what we use for hypertension trials. So as a trialist, we always try to focus on evidence-based medicine and doing everything in the most kind of rigorous academic way. But the reality is, by forcing people into that paradigm, you lose people. It's a lot of asks on their time and attention. It's a lot of days of the week and hours they have to sit and measure appropriate setting, have that data sent over, make sure that the Bluetooth and the Wi-Fi connections are working well. So by relaxing some of those stringent requirements to participate, we actually saw that not only can we bring more people into the management paradigm, but we actually saw quite similar results to the people who only had a few readings versus those who had the full protocol completion of 14 readings over the course of a week.
Okay. For the one that was in JAMA, it looked like about 34% of the people were participating. I guess they did well, but they were participating. Well, that sounds like 1/3. So it seems pretty good, even though the article didn't seem to think that it was that robust. But why do you think only 1/3? Do you think it's because of the rigorous protocol that they had to actually do things instead of somebody calling and doing it for them and say, how are you feeling? What are the symptoms? Because they had to do more?
I think it's a really good question, and there's a couple different ways. And we did some qualitative surveys afterwards, so I can give you a little bit, not quantitative, not huge numbers, but we got a little bit of feedback from the patients that participated in the program, and I'll share some of those anecdotes as well. If you look at the 34% who completed the entire program, there actually was a much larger percent that completed part of the program. So where we see 34% is who picked up every phone call or returned every phone call, took every recommendation of a medication change or a new medicine, and got their blood pressure to ACC AHA directed target. So that's less than 130 over 80 millimeters of mercury. Now that is a pretty, not every society agrees that that should be our end goal and target. So that's part of, I think, the challenge for many patients is, while I would love if every patient, based on the SPRINT data and other large, well-validated international clinical trials, I think that data point, that 130 or 80, really is the most evidence-based in terms of what our goals should be for blood pressure targets. Other societies and other metrics of success for blood pressure end up at 140 systolic and 90 millimeters of mercury diastolic. And so while the data suggests that that is not protecting you as best we can from things like heart attacks and strokes, it's become permissive amongst some providers and thus among some patients that, well, why are you pushing my numbers so low when some of the data in the literature says that 140 is okay? So I think what we get challenged with at times is inertia can be challenging to overcome. And if one doctor is saying something different than a different doctor, and the doctor that's saying you don't have to take more medicines, the numbers that we look at look okay.
Yes.
It feels good to hear that I don't need to take more medicines and that I don't need to be more aggressive about my blood pressure management, and my numbers are not putting me at additional risk. Now, again, doctors can disagree.
That
And so
happens
there's
often. That happens, yes.
It does. And so I think that's part of the reason we saw some of this drop off, where we were pushing quite, in some folks' words, aggressively to that 130 millimeters of mercury goal. We feel that that's the best evidence-based number to target for patients to really reduce their cardiovascular and kidney risk in the long term. And so because of those discrepant advice that some patients were given, they would hit the number of 140 and say, I think I'm good. My doctor thinks I'm good. We're going to not keep on going here. So I think that accounts for 20 to 30% of the patients that we were caring for. They would go back to their doctor and say, yep, I'm working with this program, this remote team, and I'm at 135 now, and they're pushing me down below 130. And their doctor would say, I think you're fine. 135 is pretty good. It's close enough. We're going to, I'm not going to make any more changes. We would call back and say, all right, we're ready to get you to your target. And they would say, well, my doctor said that I'm not so sure that we need to keep on going or make any more changes. And so, doctors can disagree. So I think that was one piece of it. There were a lot of, that life happens paradigm is also common, right? I just had a grandkid. Thanks for all this intervention, but I really need to go help my daughter raise their child for a couple months here. My husband just a couple of years. Your daughter, I'm jealous of your daughter. My husband just got diagnosed with cancer. I can't really be going to get my labs every other week now while we titrate these medicines. I'm going to focus on him for a while before we return to this. My job's really stressful right now. This is not the right time. I'll come back to the blood pressure another year, come back to me. So I think there's just, the reality is life happens and not everybody wants to think about or focus on their health all the time. And I think that there's a big source of inertia where, if is close enough good enough. The data would suggest maybe not, but I think we like to think we're invincible. And while the evidence-based medicine pushes us to really try to do our best at a population level to get as many people to goal as we can, this is an individual phenomena, right? You've got a patient sitting in front of you, got a patient on the other side of the phone, and you really want to be able to work with them and not kind of be too paternalistic or judgment inducing when you have some comments or feedback from them and how they want their care to be dictated.
Yes. How was AI involved? I know it was in the selection, but when you were doing the monitoring and evaluating and teaching, was AI involved in that aspect?
Yeah, during that trial, no, we are starting to do some more work now where AI can be involved in education. So you can think of things like avatars. There's some really impressive technology around simultaneous translation with video conferencing. So being able to speak in English in my natural language and have a simultaneous avatar speaking in Japanese or French or Spanish or Haitian Creole to a patient on the other side of the video screen is actually very impactful. It not only takes out friction, but it certainly adds an element of understanding and really being able to engage in patients in meaningful and powerful ways that has been challenging. So some of our communication, some of our education is incorporating some of these new tools, not only in translation, but being able to actually create avatars that can respond to a standard FAQ template, right? So people like to hear from their clinician, a friendly face and voice that they
Yes.
know and trust, and being able to ask questions of them kind of on demand. I think access is a major problem right now, right? So being able to say, yes, here's the evidence-based standard answers I can give. Of course, there has to be safety and quality around, well, if they ask you about the weather or what they think about the situation in the Middle East or the politics of the moment,
Uh-oh.
off limits. But I think being able to give them important medical information about their health, about their medications, about their disease course, or additional diagnostic or treatment plans for them, I think can be really important. I think doing that in a way that doesn't that doesn't give misinformation or half truths, I think is really important. So I think those types of tools are starting to get more evidence behind them and are starting to get more uptake. I think doing that in a monitored fashion where there's always kind of a backup person, people, or team, so that if somebody has an additional question or there's something that wasn't clear, I think that's just something that you're going to see health systems start to work out and walk through with trepidation. Because I think, again, with generative AI, part of the challenges are you can't always 100% predict what is going to be inserted as that next word or that next sentence. So I think that's something that health systems are really working to make sure that they feel safe and good about, that anytime something is touching or interfacing with a patient, it's not giving inaccurate or advice that wouldn't be given by a doctor in the same situation.
Yes, because I was thinking about maybe why people didn't complete, and it's for all the reasons that you said, but I was just worrying about the educational piece, and everybody's at a different level. And if there was some AI training that they can go through as to what hypertension even is and why it's important, because they call it silent killer, out of sight, out of mind, and maybe they don't see all of the effects of it. Many people don't. Diabetes, here's a number. I know you can see the number with the blood pressure, but I don't think that they realize all the things that hypertension actually causes. And so maybe some more training, and if AI would be perfect for that, to help answer questions about why this is important. Just some thoughts about maybe adding something to the study to make them more compliant or maybe understanding. I'm just thinking about the teaching. It's got to be difficult and everybody's at a different level. So maybe you have different levels of this and you can skip the easy parts if you already know that. And
Fantastic idea. I think you're right.
So we're going to be talking about EKGs just for a minute.
It's so exciting.
And just for our listeners, where things have moved is that we always rely on ordering the echo and waiting for AJ to read the echo and then deciding what to do. But we're at a point where if you have an EKG in your hands and you have AI interpret it, we can know things that would be on an echo. So Anne has some specific questions around that for certain diseases.
Well, just heart failure, diabetes, hypertension. So it can predict all of these. And the big one, and we wanted to ask you about, was atrial fibrillation. So, assuming that the EKG is normal sinus rhythm, and AI can now predict the future of you developing atrial fibrillation. Speaking about just the AFib, what do you do with that information now that we have it? Something, be careful what you wish for, because we need to do something with this. Do we treat? Do we put a monitor? What do we do with that when we find out, like for yourself or for us, if I knew I'm going to be getting atrial fibrillation, what do I do?
You're asking a really fantastic question. And I think,
I don't know
the
if there's
short
an
answer
answer,
is
just your thoughts, just your
yeah,
thoughts.
we're in a data-free zone, as we often are in medicine. And I think we're just to like double click a little bit deeper on this. I mean, this is fascinating, right? Like now these EKGs, these diagnostics that we took kind of at face value, there are pieces of that we forever have been trained, as a cardiologist for years to understand what does each bump and squiggle really mean to me and to the patient, and what is that gonna change my practice or my management recommendations for this patient based upon. We're in a world now where there's so much data richness in each individual aspect of this EKG that a human eye could never see or understand. So it really is just phenomenal. And a huge credit to one of my colleagues, Dr. Pierre Elias at Columbia, who's led a lot of this work, some fantastic trials and studies in identifying the presence or the likelihood of structural heart disease from an EKG. I mean, just fascinating and really important clinical workflow changes that I think are going to come on the heels of some of these new innovations. But to your point and to your question, it is a really tough question to answer. I'll even take a zoom out and say, what do you do if I told you this EKG could tell you your likelihood or risk of dying in 10 years? But I couldn't tell you what it was from or how it was going to happen or what could be related or what do I tell you to do? Oh my goodness, enjoy the next 10 years. It's a really it's a very challenging position that we're getting put in, and we see this a lot as cardiologists. Risk of AFib, like in practice these days, I would say, look, here's things to watch out for. I would watch out for feeling lightheaded, feeling dizzy, getting short of breath, having any palpitations or episodes where you're feeling weak or tired out of the blue. If those things happen, please call me because I would want to put on a monitor. Some of my patients, that happens all the time, and that's just true of life. And I say, okay, you know what? I'm not going to put on a monitor every day, every week, every month. If somebody really has a lot of concerning symptoms, do we consider an implantable loop recorder? More often, I tend to avoid invasive things when I can. There's a device called a Cardia device. It's a little 2-lead EKG. You can kind of put your fingers on there, Bluetooth into your phone, and those can be sent over to your provider as a PDF or a secure patient gateway. So are there ways we can say, what, those types of episodes, when they're happening, you are very clearly in normal sinus rhythm. I can provide some reassurance here. It doesn't look like you're in AFib right now. So good news, we can keep on keeping an eye on it. But at the moment, it seems like we're all good. There's other things that are like the Apple Watch is actually really great at looking for that irregularity. So as a screening tool, I think can be a really powerful way to make sure that we're doing everything we can to capture these things earlier on. Because what you don't want to have happen is get an EKG. This person has high risk of having future AFib in the next 3 to 5 years. We say, all right, let's watch out for these things. At year 4, they come in with a big stroke. Again, God forbid. So I think we're all still trying to understand what are the right approaches and interventions to take to try to catch these things ahead of time and not after an acute event. So again, there's no data. I'm opining on my clinical personal practice. But I think it's going to take some good randomized trials and some evidence generation to really help guide our hands and what's the most safe and appropriate approach for these patients.
So I wonder if we could get insurance to cover an Apple Watch. Just thought of that.
For screening.
A high risk for developing AFib.
Yeah, Anne spoke with me at an AI conference recently in Paris where she talked about the hypertension notification feature on the Apple Watch. And again, looping back to your work in hypertension, that could just be spectacular. Just one more thing about the EKG. You published a paper on artificial intelligence to diagnose hypertrophic cardiomyopathy from an EKG. Just any thoughts on that?
Yeah, again, I think it's really fascinating what some of these new tools can do. And I think, the question is going to become, and this maybe I'll tie into that study specifically, right? Hypertrophic cardiomyopathy is a quite uncommon condition. Is not one of the most common things we see, and a lot of people get EKGs. And so here's the challenge that I'm starting to be faced with as we start to consider this at like a systematic and a population health level. Even if the test is really good, right? Like let's say 90% sensitive, 90% specific, those are pretty good test characteristics. If you're talking about a rare condition and a commonly done procedure or diagnostic, the vast majority of patients that are going to screen positive based on this test, even with good test characteristics, because it's a rare condition and a commonly done procedure, it's going to be mostly false positives. So I think the challenge that we're being faced with as cardiologists and as clinicians and people thinking about population health in this sphere is how do we not overly get people nervous and say, oh, there's evidence that you might have hypertrophic cardiomyopathy based on this EKG alone. I'm going to get you an echo. I think you mentioned echoes a few moments ago, right? Like echoes are, there's waiting, there's cost associated with that. It's a diagnostic that can be very powerful, but also in and of itself can lead to things that have to be monitored over time. I like to use the kind of lung nodule example. If you get X-rays on every single person in the entire, in the entire United States, you're going to have a lot of incidental findings that are going to lead up to a whole bunch of follow-up, either CTs or MRIs or repeat chest X-rays. And again, the data says that screening at a population level for things like that might actually not be cost effective. The quality adjusted life years that we're adding by doing all this additional testing and radiation might not end up being good for patients or populations at that scale. So I think when it comes to these types of tools and how they can help us in our diagnostic and therapeutic intervention recommendations is really still going to be, and this is why my strong bias here is the clinician's role is still going to be very important, because you can't take this as a completely population-wide shotgun approach and just apply this to every EKG that gets done across millions of people, because what you're going to find is that you have a whole ton of false positives. You spend an enormous amount of time and energy kind of sifting through that list, creating incidental findings that then in and of themselves have to be followed over time. And in doing so, you're really capturing the net new patients that you're identifying and capturing can be quite small. So I think that how and when, with great power comes great responsibility, right? The old Spider-Man saying. But I think it's only so true when it comes to, when is the right test for the right patient and in what circumstances should those be applied. I think that's going to become such a vital skill that we're going to need to really train on and wield as clinicians, so that we can appropriately and effectively care for patients.
Wow, that was so well said. And it really focuses on the importance of physician leaders in AI and healthcare. And we really are so impressed with all the work you have done. We both have one final closing question that isn't about the data or the evidence, and it's just your opinion, and that is the whole crystal ball idea. So if we looked into the future,
10 years.
10 years from today, what do you see AI and cardiology looking like a decade from now? Just your thoughts.
No wrong answer, because nobody knows.
Yeah. I will say I see a lot more happening kind of on the assistive side, right? So I think there's going to be a lot more. We're already seeing, if you've heard of the Advocate program through ARPA-H, this is a government grant agency that's really looking forward to deploying agentic AI in care delivery. I think that is a really exciting area. It's also something that's going to need to be monitored, studied, watched, and really overseen in a very, very careful way. However, I think it provides an enormous amount of opportunity, because what we see, access is a major problem. And I think similarly in Chicago as to Boston, a lot of great doctors in both of these areas, and yet still to see a new cardiologist or get a new visit with your local friendly heart doctor, it can take months or longer to actually get that access. So I think, that is still going to be really important. I think having clinicians, hands-on patients, doctors in the loop is still going to be an essential part of practice. But I do see a lot more of, once the plan has been set, once we've come to an agreement on what the right cadence of monitoring or the most appropriate therapy recommendations that are going to follow after this appointment, I think a lot of that is going to be managed by agents or systems, as opposed to come back in a follow-up visit in 6 months. We'll see how you're doing on that med, and I might titrate it. I might add a new med, or I might, consider a different line of therapy. I think so much of that can be done asynchronously with systematic oversight and intervention, really augmenting clinicians so that, there's always a care team in the background. But I think so much more of this is really going to need to be taken over by these types of autonomous systems that can actually close the loop, take the next step, and pull in a physician, clinician, human oversight when identified and appropriate. I think that's the world I see 10 years from now, where we're augmented by not just APPs, but AI agent APPs that can do a lot of the intermediate steps before the next procedure or major fork in the road where a decision needs to be made, a procedure needs to be done. I think we're going to see a lot more of that.
Very, very well said. And I think anybody hearing what you just said would be less afraid of AI. So very, very well said.
Well, AJ, thanks for being on the podcast today.
Yes.
It was really delightful speaking with you. And we
encouraging.
We are
motivating, and I love your work.
Thank
you for doing that.
Yeah, we have such a hopeful future with AI in your hands, and you are tackling the most important problems, not just in cardiology, but in medicine. But
I mean, at the heart of the issue, in their home.
Yeah.
It's incredible.
Bravo. Keep up the good work, and we look forward to being of assistance to what you're doing in many, many years to come. So thanks for being our guest. Have a great rest of the day, my friend.
Thanks so much for having me. Thanks for the opportunity. Such a pleasure, and looking forward to seeing you in Chicago. Take care. Be well.
Bye.
Hey, everybody. John here. Thanks for listening to another episode. If you enjoyed what you heard here today, please check out our website at www.americancollegeaim.org. Sign up to become a member. Also, save the dates, October 9th and October 10th, 2026. We'll be back live in Chicago, Illinois at the McCormick Place Convention Center for our second annual live scientific session. Sign up at the website to attend. Until then, we'll see you all on the next Melvin Monday. Thanks for stopping by. See ya.